and I'm very happy to introduce and to host my colleagues and friends, Dr. Dominique Rothenflu from Oxford University Hospitals from UK, and Dr. Reuben So from Singapore General Hospital. They are both orthopedic surgeons, highly trained, strong British influence, but they will show their ways of challenging spine deformity cases from their practice. And so I would just ask Dominique Rothenflu whether he can start with his case. And many, many thanks that you both joined us from UK and Singapore tonight.
Yeah, well, thanks, Alex. Thanks for the introduction, and certainly, thank you very much for having me in this. It's the first time that I'm joining here. So I've selected a case that comes from my deformity practice. I'll just
Can you? Yeah.
let me just know whether you can see the slides. Should be all okay now. Huh? So this is a case that was referred to me for revision surgery. He's had already 2 surgeries before, but rather than just focusing on the problem that I was trying to solve, I think it is very instructive to actually start from scratch and to really understand and analyze actually how it got to that stage. So this is a 30-year-old. At the time, he was 30-year-old. That was about 10 years ago, 9 years ago, well, 11 years ago almost. He, according to the notes, he presented with pain across the apex and mainly pain in the lumbar spine. Was a bit cosmetically disturbed because he felt he had a hyperkyphosis in the thoracic spine. He had previous TLIF at L5S1, which was for spondylolisthesis and the background of a pars defect. The thoracic kyphosis measures about 77 degrees. My measurement here, I'll show you then more accurate measurements. That one here is not so accurate. Says about 77 degrees, but actually it's probably a bit less than that. And at the time also fulcrum bending was done, showing that it bends down to about 59 degrees. Are there any opinions or any ideas what you would do with this patient at this stage? He obviously came to a surgical clinic, so was asking and looking for a surgical opinion.
Did you ask whether it's the cosmetically problem that annoys him most, or what is the pain?
Well, I cannot answer that question, like 10 years down the line, but I would assume it was mostly the pain, knowing him now.
And you see quite often this disease, kyphosis, among your patients, or is this a rare case?
Well, sure, man. We usually see them in of course in younger patients. Not so. I see some that come typically in their 30s, maybe early 40s at most. In most cases, they would have had surgery already in adolescence or earlier adulthood. So in this age group, I don't see it that often actually. Overall, it's not as prevalent of a pathology as compared to scoliosis, for example.
So the patient seems to be balanced from the sagittal balance. I think it's hard for you to divide the pain, thoracic pain, from the lumbar pain after previous surgery. I think the pain history will have been a challenge for you.
Yeah, well, I mean and I think that was the rationale for discussing surgery with him at that stage. Very often the hyperkyphosis triggers a compensatory hyperlordosis in the lumbar spine, where at some point the range of motion of the facet joints are exhausted, and that will give him pain in the lumbar spine. So, especially in younger adults presenting with this type of phenomenon, we then tend to offer surgery to reduce the kyphosis, to essentially reduce the hyperlordosis and treat the compensation mechanism with it, and that usually results in a resolution of pain. But here I've, like going through the case again, I didn't find the thoracic kyphosis actually that extensive. And at the time I thought probably the surgeon here must have thought, well, it is some sort of compensation mechanism that will give him pain. So maybe by reducing the kyphosis, the pain will be treated. But I would say, like the patients that I consider for surgery these days for this type of pathology, they would have more of an extensive, the kyphosis would be more extensive than this. Then are you moderating the chat? Imaging with arms out under, yeah, exactly. That's a good point. That's not how we do whole spine x-rays at this stage. The arms out, and probably the radiographer at that time told him to hold on to a pole or to something to stand still. Whereas we know now that actually the best way of judging the sagittal plane would be with the fingers touching the clavicle. So that's not an X-ray that we use. So it could actually underestimate and underrepresent the kyphosis, which is correctly mentioned here in the chat. Yeah.
What do you think? Start with this is Ali Baj. Thanks for this case, Dominique. What do you think of starting out with some physical therapy or some non-operative management for the pain, and then maybe surveillance imaging, or bring them back to clinic in a few months?
Yeah, I mean, I tend not to operate on these patients, but when I meet them for the first time, especially adults, I will see, what sort of rehabilitation program would they have already done? Have they really exhausted non-operative measures? And then, we balance the treatment options. I rarely tell them that surgery should be the option. I'm actually never, the first time I meet them. So I personally, if I didn't see him, 10 years ago, but if I did, I certainly would have tried to exhaust any sort of non-operative measures, definitely. Good. So would somebody not operate on him? Somebody in the chat is writing for 80 plus degrees. Yeah, I would agree. Spine x-rays in addition to exam key to a postural kyphosis. Yeah, that was a supine x-ray here that we see on the right. Fulcrum.
And what was the change of the degrees?
Well, here it says about 60 degrees, but it's kind of hard to say how much this relates to, I don't really know which segments that we're actually looking at, but it looks a bit like it's across the apex, so about 60 degrees. So that would give us a flexibility of maybe something like 10 to 15 degrees. So not a huge deal, but actually in adults at this age, it is usually, the patient already has anterior osteophytes here, as you can see throughout in the x-ray. Those are usually not that flexible anymore.
Dominique,
so that's pretty much what I would about expect in this age group.
Can I sneak in another question, please? So this is interesting because the patient also has that pars defect that they needed a fixation for. So how this comes up, not infrequently, but when you have a pars defect spondy with scoliosis, let's say even operative scoliosis, say in an adolescent, or in this case, you have, let's say, a symptomatic pars defect spondy with a kyphosis. Can you just briefly talk to us about what your thought process, which one do you fix first? How long do you wait before you fix the secondary issue?
So in an adolescent with a scoliosis and a significant, maybe even higher grade spondylolisthesis, I would fix the spondylolisthesis first, because as you correctly say, there is cases when the scoliosis actually corrects spontaneously after fixation of the spondylolisthesis. I've not actually seen this for thoracic kyphosis, but depending on what I guess it depends what the extent of the problem is. I would assume that at some stage he would have had radicular pain, in which case it probably would have made sense to also fix the spondylolisthesis first before actually venturing into the thoracic spine.
Okay, but I did get it right. That time it wasn't your patient.
No.
Okay.
Dominic, can I just ask a quick question? So, does he complain of difficulty with horizontal gaze?
No, not at that stage.
Okay.
He wouldn't. Well, with actually even 80 plus degrees kyphosis, if they're thoracic, younger patients like this, the horizontal gaze is not a problem at that stage because they compensate in the lumbar spine. So let's go to the next. So yeah, so that was done here. A patient had surgery. Surgery was offered, and this fixation was done, which extends from about L2 down up to about T2 probably, with the at the UIV with 2 hooks. But anybody want to does that look okay? Would you have chosen the same fusion levels?
What's I'm sorry, the UID is T2?
Yeah, I would say about T2.
And LIV?
L2.
L2.
So yeah, 3 discs left here.
Yeah, I mean, I personally think the choice isn't necessarily a bad one. You know, I mean, there are a couple of techniques that people use. Usually, if you want to be safer, you can always go down to L2 or L3. If you want to maybe take a chance to be a little bit more, you want to spare some discs, you can go -1 to L1. But I don't have a problem with that. The problem I have is with the indication.
Yeah, I would agree with that. Yeah, absolutely. I saw him much further down the line, so we cannot change the indication, but I would agree with that, and when we now see the further course of the problem, if the primary indication is absolutely key, because once you start doing these corrective fusion surgeries with the instrumentation, you've opened Pandora's box, right? You can never undo it again if secondary problems come up. And I guess, okay, but we're gonna talk about. There's a number of things one can comment on here. If one looks at the alignment and the distribution of the curves already qualitatively here, if you think about the Rusoli classification, but we'll get to that again in a more also quantitative way. This is just to illustrate where the case actually is going. Anyone guessing what comes next?
So what are your thoughts about his neck alignment after surgery? Do you think this is just postural, or is this reduced cervical lordosis because you've decreased his thoracic kyphosis?
Yeah, I'm not really sure. Do you think it's reduced cervical lordosis?
It's a little bit hard. I'm looking at this over my phone right now, but it looks like his horizontal gaze is a little bit different than it was in the preoperative period. But maybe it's just the way that he's standing up postoperatively.
Yeah, that's hard. I find that hard to say, but certainly something strange is going on there. Do you want to guess what comes next?
Well, I'm assuming he's going to end up either getting PJK or his bottom screws are out there.
Yeah. 6 months later, it looks like this. And that's a year later. At which point, patient apparently was in complete agony. And we can talk about this a bit more. That's actually the alignment, all the precise measurements. And from a qualitative point of view, what I wanted to get at, what may be wrong here is that the way this was fused here. Can you see my mouse pointer? Yeah? No. Can you see my mouse pointer now? Yes. The way this was fused here and corrected, it actually extends his lordosis way into the thoracic spine up to about T10. So his lordosis is way too long. and that then has implications and you know how he has to compensate, and the only thing he can compensate is potentially in the lumbar spine, but then in the non-fused areas. And you know, if you talk, for example, there's something that I picked up from Ibrahim Obeid. He once said in a course where we were both teaching at, well, actually, you know, whether we get it right or not is not by looking at just at the metalwork. Actually, you should really blank it out and see what the non-fused parts of the spine do. And only if they behave in the right way, that's when it tells you whether you got it right or not. And clearly, when we don't look at the instrumentation here, the way the non-fused spine behaves, that didn't dial in and dial in the right shape of the spine and the right amount of curves, because otherwise the patient would not have had to compensate in that way. So at this stage, he was clearly in agony. And now the big question is, you know, what next? The patient still wasn't referred to me at that stage, so I couldn't make that call. But, you know, the question is, what next? Because we're dealing here with a balanced spine.
So the funny thing is, what comes next is always diagnostics. Can you show us maybe some CT scans and MRIs so we can?
I don't have an MRI.
See them out.
Maybe there was one, but just, you know, the CT. That's what happened there. So the hook's kind of disengaged. You can see that here, and the spine essentially fell forward. So the kyphosis is within that disc space.
So there was a pseudoarthrosis in a fused part, the upper fused part of the spine, isn't it?
Well, yeah, probably you can call it that way. It's a, you know, it's a proper PJK, or maybe even PJF, because he was very symptomatic, not neurologically, but at that stage he was in absolute agony.
So he will sign everything, every solution you will offer. The question is, how far do you go high?
What I mean, we're not. This is not an easy situation, because he clearly has a problem. But, you know, most potential solutions, and we'll discuss. I'll show you a bit more about the thought process here. Most solutions will put him right back into the situation that caused the problem.
Yeah, this is really hard. You have to consider whether you do the whole case from the beginning again, and if you not only solve the problem of the pain in the PJK, the question is, can you do the realignment in the sagittal curve so that the PJK is solved, plus all the stuff like cosmetically, like looking standing upright, is fixed too. This is a double difficult situation. If you have a young man, 38 years, I think you can say, okay, if we go for revision surgery and we have to, then we go very big.
Yeah, so that was also, there was another surgery that was done here, and then the patient was referred to me, and that was basically also I was considering all these options, and, you know, like, to completely change the whole alignment of the spine and the distribution of the curves would have essentially meant to completely fuse the spine, which of course we tried to avoid, because, you know, he's still relatively young. He doesn't necessarily want to have completely fused spine. Well, what would be the easy solution? So the surgeon here didn't go for anything too clever.
So the easiest solution would be the smallest surgery. It would just address going perhaps 2 levels more high and try to fuse it from the back without restoring the balance. This would be the easiest. Maybe you have got
he's balanced. That was exactly the point. Yeah, exactly. I mean, the easy solution would just be extending the fusion, right? Saying, well, the spine's rebalancing. If he's got pain because it's not fused and there's no instrumentation holding it in place, maybe we can just extend the fusion into potentially the cervical spine and keep it in that place. That could be a good option. And yeah, well, that's exactly what was done, but it was not a good option. So the fusion was extended here up to C4, and essentially put him in a position where he then actually struggled maintaining a horizontal gaze, and had pain, neck pain, shoulder pain, and particularly also headaches. So that's where we're at now, and that's where I got the patient. So he's now 48 years old, with a PJK after correction of a thoracic hyperkyphosis, with an in situ extension of the fusion into C4. That was 7 years ago. He comes to me with neck pain, headaches, struggles to look up, has a high chin brow angle, and the question is, what now? Well, I can tell you, he was referred to me. There's like, well, just do an osteotomy up there. Question is that really a good idea?
Yeah, you're pushing me to the limit. I think it's really hard. The measurements with this kyphosis, with this hyperkyphosis, I think
let's think it through. I mean, if we start analyzing the spine, this is a Cheops analysis here. Well, probably we should start understanding, because like in revision deformity, what we should treat the driver like in any sort of like deformity, and not the compensation mechanism, right? The PJK here can be regarded as a reciprocal change or a sort of a compensation mechanism. So if I just treat that, then I'm not actually addressing the driver, and could cause even secondary problems further down the line. So because the spine's balanced. You look at C7, it's just right over the sacrum. That's the purple line here, right? Spine looks balanced, head is a bit forward. And of course, because he's fixed here, he struggles to look upwards. So all he can do now is kind of extend here a little bit and in his lumbar spine. But from here, he's completely fixed, and that's part of his problem, really. So the PI here, I measured earlier about 58, 60. The Cheops here says it's about 66 degrees. He has a slight hyperlordosis, and what's really obvious still is that the lordosis is just way too long. It is extending into the lower thoracic spine, right, which it should not do. Where's my mouse pointer? And this has probably, the way the instrumentation was put in has probably pulled the thoracic spine also too much backwards. So together with the long hyperlordosis and with this kind of almost it, if you put the spine of the head onto here where it actually would belong, and you drew the C7 plumb line, the patient would be negatively balanced. And that, in my view, is really the driver of this PJK. Because of that, he basically had to tilt his head forward in order to keep the head above the sacrum, above the femoral head. So in that sense, the thoracic kyphosis actually seems to be overcorrection with actually a creation of lordosis in the thoracolumbar junction, which should not be lordotic, really. So this, analyzing the pelvic incidence tells us it's a Rothenflu type 4, but here presenting as a balanced false type 3. So it gives the appearance of a type 3 is balanced, but is actually a type 4. So the patient was referred to me for a PSO in the upper thoracic spine. Now, with what we've just seen analyzing the sagittal profile, is this really a good idea? Just to do a PSO here? What happens if we do a PSO here? You get a really good correction.
Yeah, the patient will run into the next PJK to correct the plumb line if you put him backwards, as you've said.
Yeah.
I
so
have.
What should we do then if we can't do a PSO there?
Yeah, you make your osteotomy down where the hyperlordosis is in the lower thoracic spine.
In the lower thoracic spine, yeah. So you lordose him even more with.
No, it's
with
not
the C7 plumb line here.
No, it's not a lordotic. You mentioned that he has too much lordosis in the lower thoracic and the TL region, and when you want to correct it, I doubt that anybody agrees that an osteotomy with the aim to kyphose the patient is really often performed. I think you can't do this because everything is fixed.
It's a wicked thought, isn't it?
Yeah, it's wicked. If everything is fixed in this position, you will run into problems with the plumb line going into the unbalanced situation. It's really hard. I think it's a lot of theory at this time.
What would one have to do if you wanted to, completely restore a Rousseli type 4?
In this situation,
well, you would have to we would have to dial in more low doses here, probably do a PSO here, kyphose here, and do a PSO up here, and then you get a nicer profile, which essentially means like something like a C4 to pelvis fusion. That was something we discussed, but I wasn't really keen on doing such a thing in a 48-year-old. So I really, really wanted to keep those motion segments intact, and such that he has still some mobility here. So I simulated this, and that was exactly it. Like performing just a PSO at T2, and here a 30-degree correction. That's probably a bit sporty in an upper thoracic PSO. Usually don't get that much correction, but I was simulating that, and you can see how this essentially puts him in a negative balance, and that's also reflected in the SVA, which before was pretty much around 0 or slightly positive, and now it's minus 24 millimeters, or an inch posterior, which exactly as we just discussed would put him right back into that position that created the PJK in the first place. Also, there's a bit of danger, like we can also already anticipate a bit what could happen to this horizontal gaze. The spine is fused up to C4 here. If we put him too much backwards, that may overcorrect almost his chin brow angle. So we certainly would want to avoid this situation. And as we just discussed, if we wanted to restore the type 4, it would really require to increase the lordosis from L4 to S1, because he, of course, has a TLIF here, which didn't give him any lordosis. Then decrease the lordosis in the thoracolumbar junction, and still perform the PSO at T2. But as I wanted to keep his lumbar spine mobile, I didn't opt to just go for a to create more lordosis from L4 to S1. I opted exactly, what you suggested, to do a kyphosing osteotomy in the thoracolumbar junction, because in order to correct this and be able to do a PSO here, to get him out of that negative balance again, I have to correct the hyperlordosis in the thoracolumbar junction and do an opening osteotomy here, which I plan to be about 5 degrees, or I wanted to open it about, because he had a fusion mass there, which I had to take down. So I wanted to open that about 7 millimeters in order to bring him back into into the balance. And that's the planning I got, which I actually quite liked. And this is then what I got. I've just seen him now for a 1-year follow-up. The correction is not as dramatic as expected, particularly as the upper thoracic PSOs. They've never given me as much correction as I really intend to. Most importantly, his chin-brow angle has improved. His chin-brow angle has improved. So he finds it much easier to look straight. He doesn't get the pain anymore by trying to pull his head up. And most importantly, his headaches are gone. So even though the correction I feel was, when I look at the X-ray, I go like, I should have achieved more probably. But the clinical outcome from the patient's point of view was he's very happy with what could have been achieved, or what was achieved. He's not entirely pain-free, but that's something I never promised. We just essentially wanted to get his head position and neck position better, such that he doesn't struggle as much by keeping the head upright, maintaining horizontal gaze, and above all, get rid of the headaches. And that's what we could achieve with this case.
Oh, so brilliant, Dominique. I didn't expect that. I thought you would go to an OC pelvic fusion. And this is, I've never seen really a lot of osteotomies which kyphose the patient. And this in revision surgery, after the previous surgeon has put him into low doses, maybe the wrong place. It's really, it looks nice when the patient is fine and the symptoms are better than before. What I like is you didn't extend it to the OC pelvic fusion.
No.
I wonder if anybody has got many experience with kyphosing osteotomies. I just want to ask the hosts, is there anybody who can tell from their own experience?
Hey, Alexander.
I think, sorry, go ahead. Go ahead, Mike.
Oh, hey, Dominic, great case. I got one of these recently, kind of at the point where your colleague got it after the initial failure. And so there was still some flexibility in the fusion mass. So I was able to go back in and do about 5 to 6 pontes via the fusion at the back and restore the thoracic kyphosis at the apex of it. But I think, you've done a great job here, because with a mature fusion mass, in an older patient, that's not going to be possible. So I've never done a full reversing osteotomy like this. I thought about it in this patient, but I was able to get away with just the PCOs because of the fusion wasn't mature. So great job. Yeah.
Thank you. Yeah, the opening osteotomy was surprisingly easy to do down here. Luckily, he didn't have a fused disc space, otherwise that would have been much harder, of course. But after I took down the fusion mass, which I essentially did with the bone scalpel, essentially just cut right through, I was just able to open it to according to my planning. So I didn't think it would go that quick. Yeah.
So awesome, Dominique. So I would love to hear your comments on Dr. So's case. Reuben So from Singapore. Maybe you can change your screen. It's 6 o'clock in the morning now, 6:30 now, and Dr. Reuben So from General Hospital in Singapore.
Can I ask one quick question on that last case?
Yes, Nader?
Sure.
Are you able to hear me okay or not?
Yeah, I can hear you.
Yeah, I can hear you.
Hey, it's Matt Goodwin. Sorry, a little late to the party here. That last case, how, first of all, great solution to a bad problem. How much do you look at those discs that you're leaving free in the lumbar spine? And if they look particularly terrible, would that push you to change your mind in what you did? Or are you going to give it a shot pretty much either way?
Yeah, I do look at the discs, and of course, if the disc space had been fused, that would have not been possible to do, really, right? Then you would have had to do a much more extensive release in order to kyphose it. In general, if the disc looks a bit ankylosed and there are already spondylophytes, I worry much more about actually reducing, correcting, you know, like doing ponte osteotomies, they don't close down as much, right? However, I would not worry about it as much by extending it. That is usually just a lot easier. Once you've taken down the flavum, extension is easier than compression. So in those patients, you know, older patients with a relatively ankylosed disc space, they clearly have spondylophytes, and then you do your good ponte osteotomy, and then it just kind of doesn't close, and you're on the Jackson table pushing down, and it still doesn't close very much. So I've been in that situation before. Whereas, however, stretching it, extending it is a lot easier.
And then what about the lumbar disc below that you're leaving unfused? Do you look at how beat up these are or not?
No, I haven't. Not specifically. I don't remember the MRI scan actually. But you know, he didn't have. I mean, the pain down in the lumbar spine wasn't his main problem. So you know, like I wanted to. I wanted to leave them unfused just to give him mobility, and secondly also to allow the spine to find, and once I've done this, you know, he will find a new equilibrium, a new balance, right? And when with 3 discs unfused, that's possible. If you fuse everything, then all he's got to balance still is the hip joints, right?
It's a great solution. I mean, that's a great case.
Thanks.
So Reuben.
Yep. So thanks for sharing that case, Dominique, and to Alex and to Ali for this opportunity to share a little bit about my case. So I think we're sort of switching gears slightly from more adult type of case first to something a bit more with a slight pediatric twist to it. So my name is Reuben. I'm one of the spine surgeons at Singapore General Hospital, and let's just show this case today. So this is a 21-year-old male with who is quite light. His BMI is only 15. Known case of neurofibromatosis type 1 with previous instrumentation performed by an anterior approach when he was 7 years old. So now he presents with gait instability and pain in the thoracolumbar kyphosis. He's able to ambulate, but he keeps looking for a place to sit down. These are his clinical radiographs. You can see that there is a cafe au lait, large cafe au lait on the chest region, and of course multiply on the back as well. And you can see that he has a large kyphus at the lumbar spine. And you can also appreciate that his pelvis is fairly tilted.
And at this age, he is 20 years old.
Now he's 20 years old. That's right. 21 years old. Yeah. So these are his history of his radiograph. So he probably, I think most of you will recognize that he has a very dystrophic type of curve at 6 years, 7 years old. You can see it's a short, sharp curve with also penciling of the ribs. And of course, at that point of time, one of the surgeons decided to fuse him anteriorly. And immediately, I think we appreciate that the fusion may not have been extensive enough to secure his lumbar fusion. But I think the magic of young children is that they can compensate marvelously. And he just went on life to proceed through his junior school and high school, and went on to do even a technical diploma. And so he only presented now back in the clinic at 21 years old with this deformity. And so I think this is quite a challenging problem. I think you can appreciate that there is a large kyphosis, 100+ degrees. And in reality, I think it's quite difficult to measure the degrees on the X-ray because of the rotation of the spine. And one can also see that the patient has basically made his thoracic spine into a lumbar spine with so much lordosis of the thoracic spine in order to continue to achieve horizontal gaze. So with some MRI scans, you see that there is multiple ectatic foramen, the large deformity, thankfully no cord changes and no syringomyelia. You can appreciate the extent, and of course, with a cord in there that is in this capacious space, it doesn't quite look like a cord compression, but I think the patient had quite a lot of pain from the facet joints, and also at the same time, I think that there was an ongoing dynamic stenosis that he was experiencing that caused him to keep on having to stop and walk, stop and find a place to rest. So these are his three-dimensional CT reconstructions, which try to help you see the deformity a bit better. You can appreciate from the bottom image that there is quite a fair bit of axial rotation, and also you can see that the deformity is very complex with large fusion mass in the thoracolumbar region, but the rest of the spine anatomy, though quite curved, actually looks thankfully not too abnormal, and so really I think this beats a question: what would you do at this stage? So we can sort of give a chance for everybody to sort of chime in and offer their opinion.
Oh, Reuben, this is a case I would just like to open the discussion for everybody here. I think it's really challenging. The patient compensated for 10 years, for 13 years with his deformity, and now he's developing a gait disorder, and we have something to do. The curve is so enormous. Do you have some bending x-rays? Do you know where is some mobile spine, where is something to correct? Do you have some information about this?
Yeah, so actually I had a bending x-ray, but I didn't put it in because actually it's a very stiff curve that is just rigid.
Okay.
Yeah.
So is anybody very skilled in these enormous deformity corrections? Otherwise, I would just love to hear your next step in this case.
Yeah, we see those, but not very frequently. At this extent with those curves, but you know, like I mean, you obviously have to consider some sort of osteotomy, you know, in terms of a vertebral column resection, or even a kyphectomy. Consider something like that, and which is not, you know, given the dural ectasia that you've shown is not like the most straightforward, and if in a first step you would, I mean, I would certainly remove the metal work there that he's already got in. And then yeah, you have to consider, well, I mean, it has to be a 3-column osteotomy or anything like, and if you want to get any correction here, so that would be my take on it.
Yeah, I think there are some. I definitely went the same thought process as you, and then particularly I think as we put in implants in, like we look at implants from years before, because some of these have high stainless steel component. There's a lot of scatter on the scan, so I think removing the implant for me, I felt was quite a useful thing to do because they can reassess the spine. Yeah, so, and of course, I mean, when you see a curve like that with 100+ degrees on kyphosis, almost inevitably is a 3-column osteotomy, and often it will be a vertebrectomy at some point. So I think because time is running, I will just show the what we did. So I think step one, as some people have pointed out, I think we removed the implants. That's what we did. So we took out the implants, and we got him to do some standing x-rays. And at the same time, because of the time of removal of implant, I placed in a halo for him. And so I wanted to bring him for some halo gravity traction. So after removal of implant, I think we appreciate the spinal deformity a bit better. You can see that there's a few segments at the thoracolumbar spine with the pelvis tilted to sort of accommodate that fused kyphus. And at the same time, there's very prominent thoracic lordosis, which is really quite worrying, because of course, to me, the biggest worry is if we do any surgery for him, that we overstretch the spinal cord and result in paraplegia. And I think that also was a decision making that helped me push him towards a halo gravity traction as some sort of a priming procedure for the cord. We prime the cord for stretch, and so that will eventually allow us to do the correction without a possible injury to the cord.
Reuben may ask, how long did you leave him on halo traction, and how much?
Okay, I'm coming to that. I'm coming to that. Yeah, I'm coming to that.
Okay.
Yeah. So I took the opportunity to also do a 3D print, because I think that will really help me with my intraoperative planning, and also aid with the osteotomy cuts that we will do for the patient. So this was the halo gravity traction that we did, and you find that that he was actually he did quite well with the halo gravity traction. He started with 5 kilos and went on to half his body weight, which is about 17 kilograms at about 2 weeks. And my own thoughts about this is that, whenever you put them on halo traction, they will complain initially of the neck pain, because the neck and the thoracocervical junction is where under a lot of traction, and the facet joints actually give a fair bit of pain. So sometimes, some days you have to take a break, don't increase the weight, and of course, at the end of the day, try to hit that 50% of body weight. So after traction of about of that 3-4 weeks, this is what we got. You can see that the pelvis is starting to tilt a bit higher, even with the traction, which sort of indicates that this spine is truly quite stiff. And but thankfully, on the sagittal view in the laterals, you can see that the spine is uncurling a little bit. And I think that to me was a good sign that actually that there is some loosening of the spinal segments. And then and so what we do next is I went in to decide to do a stage insertion of implants, as well as do some thoracotomy and some releases. And at this stage, it was no correction yet, just to put in the implants. And so what have we done so far? We've done 5 weeks of halo gravity traction. We did an anterior thoracotomy, released the T3 to T9, and followed by posterior instrumentation. And you can see a lot of these small lines here on the X-ray. That's actually the sublaminar bands. And you can see that because in these patients with such a severe deformity, there is a fair amount of pedicle dysplasia, Particularly so because there is dural ectasia, and dural ectasia causes a lot of developmental changes in the pedicles, which prevents us from even having even any form of cancellous channel for a pedicle screw. And so it's back to a so-called a first generation technique of sublaminar fixation. And this you see here the use of sublaminar bands, which help to bring about a fixation point. And at this stage here, it's already probably like 7 p.m. in the evening. So there's no way that you can do the correction on the same day. And what I did do, however, is that I used all the bone that we collected from the anterior thoracotomy, as well as all these releases and the multiple pontes in the spine. I banked it in the concavity. And because at the point of time, we didn't have a bone banking facility. And so banking in the patient's own body, I felt was a good solution because we know that we will need lots of graft eventually, and the best graft is still the patient's own autograft. So as we do the surgical planning for these patients, I find that as Dominique has used as well, the use of the SurgiMap to help with the planning, and that helps us to figure out exactly what we need to do. And so you can see that the resection osteotomy here in the thoracolumbar spine is a good 45 degrees, as you can see here on the resection osteotomy in purple. And when we calculate that and look at the CT scan, it actually correlates to a 3-level vertebrectomy, which thankfully, because his vertebral bodies were so rotated, is actually rotating into your view of into your posterior view, which makes it a bit easier to perform during the time of the surgery. So the last stage was vertebral column resection. So after he recovered from stage 2, we proceeded to do that. And you can see here that this is a 3-level vertebrectomy that has come out. And once again, we inserted some more sublaminar bands for those pedicles that weren't being able to be instrumented. And of course, I found that it's very useful to have an O-arm because it helps you know exactly where your resection margins are. What you don't see in the picture also is the use of the the ultrasonic scalpel. And the other thing also is that you can see here that there's a constant use of adrenaline soaked gauze to try to control the bleeding around the muscle area. And so these are his 1-year surgery x-rays, and these are how he looks like in a year. And so I think that there's probably a little bit of pelvic obliquity still, but overall he's pretty happy with the result. And these are comparing his pre to his post-op x-rays. And so I thought it's just good to share a little bit about the literature when we talk about halo gravity traction. I think over the years, we've seen sufficient data coming out that it's a fairly safe procedure. And at the same time, most people talk about between 4 to 6 weeks of usage of halo gravity traction. And in this paper, they also note that there is an improvement in the pulmonary function for this patient. And of course, the Spinal Deformity Journal has also talked about this before. And I found that the useful information from this is that actually we need to continue to do all these checking of the pins to make sure that they don't cause any problems for the patient. So eventually, I think one of the learning points is that I think it's important to shave the hair, because the hair does grow quite quickly in these young patients, and then shaving their head actually makes it easier for the nursing side to take care of these patients in terms of the pin sites. And of course, need to continue to reassure the patient about the neck pain, but at the same time, assess him for any weakness, because that is in itself a possibility that the cord is under traction as well.
Oh, thank you, Reuben. So amazing case.
Yeah.
It is. How long did the patient stay in your hospital, or was he sent home for a while,
Yes.
or was he continuous?
So he was in the hospital for a good 2 months. 2 months. It's a long time. Yeah. So I think that unfortunately for halo gravity traction, they can't go home. And I think with most hospitals around the world having bed crises, this is always a challenge when it comes to having them to stay so long. And the patient themselves gets a little bit bored. But it takes a lot of effort to continue to talk to them, reassure them, and try to get them to understand that the importance of halo gravity traction is to prevent cord injury and also to maximize the correction eventually. So I just share a few learning points. I think I found that perhaps if I were to redo this case again, I would probably spend a bit of time to do a bit of prehab. And I think that with such a stiff curve, I would probably have removed the implants and performed some anterior releases at the same sitting, and then put on the halo traction, rather than to just remove the implant and do the halo traction, because I think that was not sufficient due to the stiffness of the spine. And I think that perhaps will have been useful, particularly with regards to trying to reverse a little bit of the thoracic lordosis. And I found that also as we use the halo at the max weight, after about 1 week or so, actually there's the law of diminishing returns. It doesn't do any more further improvement when it comes to incorrection. And so the intraoperatively, I think what I would probably do is try to shorten the interval between implant insertion and the actual procedure, because I found that because these patients, their bone is not as solid as you would expect it to be for a 21-year-old, there is a bit of loosening around the implants at the 3-week mark. And so having a shorter duration would be quite important. And I actually had a dural injury and dural tears because I was trying to cannulate sublaminar bands in a lordotic thoracic spine. And I think these are the parts that really affect the to me, it's a chink in the armor, because you're proceeding along and then you get a dural tear just because you're passing a sublaminar band. So I think this is one of the things that it's important to recognize, that when we pass sublaminar bands in kyphosis, it's quite easy because the bone is coming towards you, whereas in the lordosis, the bone is going away from you. And so that's the part where you have to be very careful when you're passing sublaminar bands in the thoracic region. I found that maybe in the post-op assessment of the pelvis, that the rotation could have been rotated even more. And so I think a good check during surgery for recheck after final locking, and then maybe performing some rotation of the pelvis may have been a better way to do it. I also found that with regards to this kind of big cases, it's good to have a pre-surgery discussion with your anesthetist maybe about a week before. Then they can give their input, find a hardworking and willing to help chat, because the anesthetists work very hard. They were transfusing colloids and usage of the FFP, and they transfused early, and they often they would constantly pop in the field, and if they saw that the blood wasn't clotting or it was very watery, they would just call for another FFP. And I think these are one of the importance of really a teamwork when it comes to this. And of course, in the post-op part, it's important to continue to have encouragement for the patient. And I think that at every stage, this chest and limb physio is important because you want to ensure that they don't lose muscle mass at the time when they are in the hospital. And we have frequent team huddles to try to discuss what's the next step and how to get him to move and to encourage him. Of course, it's important to recognize there's really a team effort, and the use of we have advanced practice nurses in our hospital, and we really hinge a lot of the treatment when it comes to wound care, pin site on these people, because they really help us watch over this aspect of the surgery in between stage surgery. So what are future directions? So I see in the chat box, there's a lot of discussion about Boachi's work. And in fact, I did show this case to Dr. Boachi to get his opinion. And I'm quite glad I did, because I think some of the thoughts he shared with me about removing the implant and HGT was utilized in this patient. You can see here that, of course, in China, now what they are doing is that they put the pins in the ASIS and PSIS. And so they allow ambulatory halo traction. And this is Dr. Liang from Chengdu, China. And you can see that he actually discharges his patient with some sort of information to the parents on how you can tighten the bolts every day to increase the tension on the spine. And so this is allows, I think, the patient to go back home, and certainly addresses the problem of long hospital stay, which many people have great difficulty with when it comes to halo gravity traction. So my take-home message is, I think, when we deal with these cases, of course, there's a very high risk of neurologic injury. I use HGT to prime the cord, and also it helps me sort of unwind some of the ligamentous tightness that is in the spine. I've used 3D printing to try to aid visualization of the complex deformity. And I bring it into the operating field because that really helps you to determine exactly where the cuts will be made. And I find staging surgery useful, but then that will result in, of course, a long hospital stay.
Oh, thank you, Reuben. This is great. This was a great case. Thank you, Dominique. Thank you, Reuben, for sharing your cases from UK and Singapore. We can learn a lot. It's so good to have a door from Singapore, to have some view what is China doing for excellent spine surgery. May I ask who will host next week? Do we know who is hosting? I think it's Dr. Marco from Texas. I remember very well, and I think Michael will host, or Matt, are you hosting?
Yes. So next week will be Dr. Rex Marco from Houston, and one of the leaders in spinal oncology. And if you haven't heard him speak in the last year or two, he suffered a high cervical spinal cord injury, and has some pretty unique perspective, being one of the leading spine surgeons in the world, and then having a major spinal cord injury. So he'll be here next week, and it should be a really great talk.
Oh, so brilliant. So again, thank you very much, Dominique. Have a good night. It's now midnight in UK, and have a nice day, Reuben. Nice evening to you, and thank you for joining, and thank you again for showing your cases.
Thank you
very much for having us. It was a pleasure.
So goodbye.
Goodbye.
Bye.